Hey guys, welcome back to the Vagus Nerve Part 2. So today we're going to be discussing about the branches and distribution through a live lecture, and then I'm going to speak very briefly about the clinical anatomy, since we're going to discuss the clinical anatomy of nerve related and nuclear related things later once again in neuroanatomy. Okay, let's head to the live lecture.
So now all these little neurons have joined to form the trunk of the vagus nerve. Fair enough. This is probably the jugular foramen intermediate compartment. I'm going to draw like whatever 9 and 11 over here. There's inferior petrosal sinus here. There's internal jugular vein here. Vagus has come down. It's lying lateral to it is the internal jugular vein. Medial to it is the internal carotid artery. It's embedded in this shield over here. Everybody okay with this? Fair enough. As the vagus nerve comes down, it has two ganglia. One ganglia is directly inside the intermediate compartment. The other is about 1 centimeter below it. Now only Varun knows what exactly a ganglia is. Safa or I forgot her name. Shifa. No, the other one. She's not here today. Bushra asked me what exactly is these ganglia. Why do you keep on talking about ganglia? So everybody knows that if there is a collection of nerve cell bodies outside the central nervous system, that's a ganglia, which means that it's just a little oblong thing inside which you have the cell bodies of the neurons that are inside the vagus nerve. Correct? Remember this. It is the sensory neurons that have a ganglion. Correct? So if I say there is a superior and inferior ganglion of the glossopharyngeal nerve, what is it carrying? It is carrying the cell bodies of the sensory neurons that are traveling through it. Similarly, there is a ganglia of the vagus nerve. There is a superior ganglion and an inferior ganglion. The superior ganglion is present in that intermediate compartment only, and the inferior is 1 centimeter below it, and it's slightly more oval, not circular. Okay? Now, remember, the first two branches of the vagus nerve, which are known as the meningeal and the auricular, actually seem to be coming out from the region of the superior ganglia. Okay? So branch number 1 and 2 is coming from this little thing over here. Technically this guy is not coming out, I'm sorry I drew it like this. This is going back in, because it's supplying the dura of the posterior cranial fossa. This is what exactly happened with nervous spinosus also, if you remember. We drew an ovale. We do the trunk of mandibular nerve coming out, but this bugger decided to go back in. See, this is ovale, this is spinosus. This is that man just decided to travel back there. Something very similar is happening here. So meningeal branch is out, it's already gone back to the cranium to supply the posterior cranial fossa. The next one is the auricular branch. Does anyone remember a small little dot
mastoid
present in the posterolateral wall of the jugular foramen? Remember? Small little wall. What is that? Mastoid canalicularis. What is that for? It's for this guy. The auricular branch of the vagus nerve, also known as Arnold's nerve, also known as Haldeman's nerve, stimulating this nerve in the olden days, whatever people used to do. People used to do all sorts of crazy stuff back then also. Stimulating that nerve would apparently induce hunger. Does that make sense to any of you why that would happen? If you are hungry and if you smell something good, can you feel that rumbling in your stomach? That is parasympathetic stimulation of the smooth musculature of your gut. Correct? So by actually stimulating that nerve, you would stimulate the vagus. Thus you would stimulate the other neurons that are distributed via the vagus, creating that typical parasympathetic chichu whatever, kotak, gudgula or whatever. Butterflies for falling in love, sorry. But whatever, that hunger wala pang. So that's why it's called Haldeman's nerve. If anyone ever asks you why, it's given in your textbook also. Fair enough? We're done with the meningeal branch, we're done with the auricular branch. Let's come to the next branch that now is coming from here. This is known as the pharyngeal branch of the vagus nerve. Do you remember the 5 structures that pass between the internal and the external carotid artery? The first structure is the styloid process, the second is styloglossus, the third is stylopharyngeus, the fourth is glossopharyngeal, the fifth is fair enough. So I'm just going to draw. Can I just draw this here then? That's kind of the internal and the external carotid artery. This is going to be the carotid body, whatever that bulging is called, correct? So here we are, this is the pharyngeal nerve. It's going to go here and it has to supply all the muscles of the pharynx except the stylopharyngeus, which is supplied by the glossopharyngeal nerve. It also supplies all the muscles of the palate except the tensor villi palatini, which is supplied by the
mandible.
You have to write all that, by the way. It's not very difficult to remember that. Cool. That's your pharyngeal branch. Okay. Let's move on to the next thing. Superior laryngeal branch. Okay. Oh, always forget this one. Little guy going over here, carotid. Carotid branch. Okay. The afferents of the pressure and chemical changes of the carotid body are carried by the glossopharyngeal. Fair enough, but somebody has to also get back, no, the single. The efferents are carried by this guy, the carotid branch of the vagus nerve. Okay? Fair enough? So we done how many branches now? 4. And this is number 5. What is this? This is the superior laryngeal branch. This is, by the way, the nerve of the 4th arch. This is, by the way, the nerve that ends up supplying the posterior part of the tongue. Just saying. So the superior laryngeal branch, after it's given off, lies on the middle constrictor somewhere, and then it just kind of ascends down to the inferior constrictor. So I'm going to draw that diagram that I've drawn the dissection all the other way, because that will probably give you some perspective. This is your hyoid bone. Remember, the middle constrictor comes like this. A couple of fibers come from the body, a couple of fibers come from the styloid ligament, whatever. This is your middle constrictor. And then you're going to have another thing over here, your inferior constrictor, which is kind of called the thyropharyngeus, which comes from the oblique line of the thyroid cartilage, and the cricopharyngeus. Remember the cricopharyngeus? Great. The superior laryngeal nerve, after it comes, somewhere near the middle constrictor region, divides into internal and external. The internal we've already seen piercing the thyroid membrane, and it's going to, obviously after it pierces the thyroid membrane, it is into the larynx, to which it supplies sensory innervation above the level of the vocal folds. Okay, it is not supplying the laryngeal muscles. Make no mistake, the laryngeal muscles develop from the 6th arch. This is the nerve of the 4th arch. It carries sensations from the larynx above the level of vocal folds. I don't know if you know what vocal folds are. You had a lecture. I hope you know that. Fair enough? Done? And the external laryngeal nerve just ends up supplying one little muscle over here, and everybody knows that.
Cricothyroid.
Because it's an MCQ. The cricothyroid. It is the only one muscle that is supplied by the superior laryngeal nerve. So probably it is the only one muscle that comes from the 4th arch, not the 6th arch. All the other laryngeal muscles, other than cricothyroid, are supplied by the just take the external. This is the external. No worry, that's cool. You can make as many mistakes as you want, that's not a problem. Recurrent laryngeal nerve. Okay? That also is the next branch. Okay? But here's the cool thing about the recurrent laryngeal nerve. I'm not going to draw it like this. This is your vagus nerve. Okay? I'm drawing all of these like this. These two technically went up or whatever. I'm drawing all of these like that. The recurrent laryngeal, I'm not going to draw like that. It's called the recurrent laryngeal. It goes ulta upwards. So it goes something like this. Understood? And this is why the recurrent laryngeal nerve is so important, because on the right side it winds around the right subclavian artery, and on the left side it winds around the arch of aorta, lying lateral to the ligamentum arteriosum. Now I'm not going to explain why this is happening, but this has got something to do with development of the arterial arches. It's a subject that will be taught to you in development of the cardiovascular system. Has that started? She said yes. Damn, son. थोड़ा alert बनते जा. Anyway, so the point here being that we're not going to talk about more details in that. Okay. So the right vagus gives the right recurrent laryngeal nerve, which is kind of whatever that thing, curling up, what's it called? Winds around or whatever, the right subclavian artery, while on the left side, it is winding around the. This is the reason why you studied lung medial surface. There was only left recurrent laryngeal. Nobody asked me, unfortunately, but if someone would have asked me, sir, what's happening to the right recurrent laryngeal? Why is that not related to the medial surface of the right lung? Because son, the subclavian artery is much higher above, so it's not related to the medial surface of the lung. Anyway, you obviously correlate all these things as we become smarter and start reading more. Now, this is recurrent laryngeal nerve. It is supplying what? It is supplying all the muscles of the larynx except the
cricothyroid.
Correct? And it is also doing the sensory innervation below the level of the vocal folds. Okay? Fair enough? So, all the muscles of the larynx are supplied by the recurrent laryngeal nerve except okay. By the way, the cricothyroid also gives a little branch to the thyropharyngeus, the inferior vesicle. This guy, this guy. यहाँ पे दे रहा है तो यहाँ पे देने को क्या मतलब है इसको है कि नहीं? So it gives a little twig over there in case someone asks. Right? Great. Sensory innervation of the larynx above the level of vocal folds is carried by internal laryngeal nerve, which is a branch of, which is a nerve of
Fourth pharyngeal.
Yeah, it is a nerve of it. Do it like crazy. How would I have guessed that? Okay, fourth pharyngeal arch. Fair enough. Now, the sensory supply below the level of the vocal cords of the larynx is taken by recurrent laryngeal nerve. Also remember, left recurrent laryngeal nerve, arch of aorta, right recurrent laryngeal nerve. Cool. Now we have finished HNF. But remember, it has to go to the thorax and the abdomen as well. We're not going to talk about those branches in detail. Okay? Because our topic is restricted to HNF right now. But I want you to go back home, open your thorax textbooks, and try to find out the course of the vagus in the thorax as well. You already know that it lies in the posterior mediastinum. Just say, apply yourselves now. Okay? It's going to go there. It's going to end up giving branches to the lungs. Yes, because the lung has smooth muscle. The lung needs stretch receptors, afferents for stretch receptors and stretch reflexes, correct? And then it's going to go pierce the diaphragm. Anybody knows through which opening you haven't done diaphragm? Esophageal opening. No worries, it's okay, it's been a while. Esophageal opening, left and right veins, okay? Esophageal opening से गया पेट में जाएगा GIT में, समझा? कहाँ तक जाएगा? Transverse colon, most of transverse colon तक जाएगा. All these details we don't want to consider right now. So these are the branches of your vagus nerve. This is the distribution of your vagus nerve. Fair enough? We do not discuss clinical anatomy here right now. But you need to start applying yourselves, and you will automatically start. I mean, you can just go home and read it, and then I can ask me if something arises, right? Because we don't have that much time. Plus, you know where I work. Anyway, so to summarize everything, the vagus nerve is the 10th cranial nerve. Write an introduction of about 3-4 lines. You've got a lot to talk about over here. Vagabond, whatever, characterless, whatever you want to call it whatever you want to. But it goes all around, giving everybody everything. Okay, that's point number 1. Fair enough. Next, mixed nerve, predominantly motor. Next, nuclear components. Remember, there is no GSE, and there is everything else. And there is no SSA. That should be easy to remember. Get a little more into detail of that. Understand which nucleus is contributing where. So you've got your nucleus ambiguous for brachiomotor. You've got your dorsal motor nucleus for GVA and GVE. You've got your nucleus tractus solitarius for SVA and GVA. Hell, that's confusing, but whatever. Then you've got your GSA, spinal tract of trigeminal, carrying only that Kankiniche or whatever, that area. Correct? Fair enough? Great. Then you go ahead and we talk about the branches and distribution. You finish, get done with the first 2 branches coming from the superior ganglion. That's M and A, that's meningeal branch, that's auricular branch, right? Both of them are kind of going up back to the skull. One is going to supply the dura of the posterior cranial fossa. The other is going to go back to the skull and again come out from, there's a suture over there, tympanomastoid or something, comes out from there and supplies this area, okay? Figure it out. Next, you've got the inferior ganglion with the branches coming from there. The first one is the pharyngeal branch. It lies between the internal and external carotid arteries. Keeps on going down, lies somewhere on the middle constrictor, contributes to the pharyngeal plexus over the buccopharyngeal fascia. Whatever, over the middle constrictor, let's call it that. Remember 9 also they went over there, pharyngeal branch of 9 with this guy is doing things, right? Also, all muscles of palate except TVP, all muscles of pharynx except stylopharyngeus, done with the pharyngeal branch, carotid branch, efferents of whatever that 9 wala, 10 wala, that thing, okay? Tight collar syndrome and all that, read about it. Next, you've got the superior laryngeal. Somewhere at the level of middle constrictor, it divides into internal and external branches. Internal pierces the thyroid membrane, supplies the larynx, sensory supply above vocal folds. External comes down, supplies cricothyroid only, sends a small tweak to the thyropharyngeus part of inferior constrictor. But that's not as important because the recurrent laryngeal nerve also is supplying there, so don't worry about that. Next, you've got the recurrent laryngeal nerve. Okay, it arises from down, right side la ikde subclavian, left side la arch of aorta, and then it travels in the tracheo-esophageal groove. Forgot to mention that. Travels in the tracheo-esophageal groove and then eventually ends up supplying the larynx, all muscles except cricothyroid, sensory supply below the level of the vocal folds. Then you've got cardiac branches, which I haven't spoken about, but just remember there is left vagus is also giving 2, right vagus is also giving 2, out of which just remember the word lisp, L-I-S-P. You know what lisp means? That thing. Can't really speak properly. You know what? You don't know what a lisp is? Whatever.
Yeah.
Left inferior. So the branch, the inferior branch of the left vagus, contributes to the superficial cardiac plexus. In case this is ever asked for your MCQs, I'm just going to put this down here. L-I-S-P. What does left inferior mean? It means the inferior branch of the left vagus nerve. Okay. The vagus nerve has. Each vagus has 2 branches, superior and inferior, cardiac branches. What are we talking about? We're talking about the cardiac plexus. Left inferior supplies the superficial plexus, superficial cardiac plexus, and all the others contribute to the deep plexus. You seem a little confused. Once again, there is something known as a cardiac plexus. There is a superficial cardiac plexus, there is a deep cardiac plexus. A plexus is a bunch of nerves. Does the heart need nerves? Yes, that's how you fall in love. But more importantly, that's how you bloody pump blood all around your body. Nervous supply of the heart. So this is your cardiac plexus. It's got superficial plexus, it's got deep plexus. Does the vagus contribute? Yes, the vagus is the chief parasympathetic supply to the heart. That's the reason why you feel calm. Vagal stimulation leads to bradycardia, etc., etc. Correct? So, the cardiac branches of the vagus are responsible for contributing to the cardiac plexus. But there are 2 plexuses. And every vagus has 2 cardiac branches, superior and inferior. So, it is the left inferior branch or the inferior branch of the left vagus that contributes to the superficial cardiac plexus. All the others contribute to the deep cardiac plexus. Fair enough? Good, that's the cardiac branches. And then you have its course in the thorax and the abdomen, which you will definitely see as you study thorax and abdomen. You will have to study thorax again, but you have a basic clue that it travels inside through the thoracic inlet, and then it will basically be a content of the superior mediastinum, then the posterior mediastinum, then it enters the abdomen through the esophageal opening. Correct? Fair enough?
Okay. Now, when we discuss the clinical anatomy of any cranial nerve, before we even start that, let's just understand what are the different types of cranial nerve lesions. In one of the classifications, we can classify them as supranuclear lesion, lesion at the level of the nucleus, and infranuclear lesion. So let's just try to understand a gist of what exactly this means. There will be higher order neurons that will come from the cerebral cortex and or the subcortical centers that will connect to the nucleus. These are known as supranuclear neurons. If there is a lesion along the pathway of these neurons, then it is a lesion happening above the level of the nucleus. So it's known as a supranuclear lesion. It has a clinical manifestation that is different than the infranuclear lesions. Now that is something that we shall discuss in upper motor neuron and lower motor neuron lesions. Okay? So the second thing is lesion at the level of the nucleus, and the third thing is the lesion below the level of the nucleus, that is along the pathway of a neuron that connects the nucleus to the effector organ. That could also be called a lower motor neuron, basically, LMN lesion. the clinical manifestation of this would be similar to a lower motor neuron lesion. So it's literally like the difference between UMN and LMN lesions. Also understand that a lesion at the level of the nucleus and a lesion at the infranuclear level would have the same clinical manifestations. And both of these would be different than the supranuclear lesion. Now, we are not going to discuss the supranuclear lesion right now because that would come in neuroanatomy. But since we are studying the head neck face right now, and most of the nerves that we are studying have a course in the anatomy of the head neck face region, let's talk about that. So you can take a screenshot of this table and then you can apply the same subtitles to all the other nerves as well. So we have on the left side the component injured. So if the component that is affected is the branchiomotor fibers, now in case of the 9th, 10th and 11th nucleus, 11th cranial nerve, these are coming from the nucleus ambiguous, the SVE. Okay. So if the palate is affected, then it is going to clinically present as contralateral uvular deviation. That is deviation of the uvula to the normal side, the unaffected side. This is because of the unopposed action of the muscles of the opposite normal side. Okay. So we all know that the muscles of the palate and pharynx are supplied by the pharyngeal branch of the vagus nerve. Except one muscle, stylopharyngeus. So if you're writing about the glossopharyngeal nerve, again you can say that the clinical sign is probably not as prominent as vagus, but still stylopharyngeus is slightly affected. So there would be difficulty in swallowing for both, but it would be more marked in case of the vagus nerve. Right? Right. So palate and pharynx usually go hand in hand. The muscles of the palate and the muscles of the pharynx are developed from the fourth arch, except the stylopharyngeus that comes from the third arch. So clinical manifestations of pharyngeal palsy would be dysphagia and loss of gag reflex. The gag reflex is again a loop whose afferents are carried by the glossopharyngeal nerve and efferents are carried by the pharyngeal branch of the vagus nerve. So for both these nerves, loss of gag reflex is a clinical manifestation. It is the reflex contraction of the pharyngeal muscles if there is some kind of a sensory stimulation to the pharyngeal wall. Larynx. Now, if the superior laryngeal nerve is affected, then its branches are internal and external, right? So the external will be supplying the cricothyroid. So there will be weakness of voice because the other muscles will still be spared, right? And there will be loss of sensation above the level of the vocal folds. And if the recurrent laryngeal nerve is affected, then most muscles are gone. So the voice will start becoming very hoarse and it will be impossible to interpret what the person is saying. This is known as dysarthria, the inability to form proper words, right? So to get more in detail about the nerves involved in laryngeal palsy, you can just check out the lecture on larynx. What is a unilateral lesion, what is a bilateral region, what is the paramedian position of the vocal cords, etc. Moving on to the next row, the visceromotor fibers, GVE. Now, there are also a few visceromotor fibers that supply the glands of the pharynx and the larynx, and furthermore, the bronchial tree and the abdominal region. So there will be reduced secretions for all these glands, and in case of the abdomen, there will always be reduced gastric and intestinal motility, right? Essentially, peristalsis would be affected. Moving on to the next row, viscerosensory fibers, GVA. I told you the visceral sensations, one of the most common ones for me is stretch. So even in the thorax, if there's any tracheal foreign body or something, these sensations will be reduced. So reduced sensations of the viscera. And finally, the last row, somatosensory or GSA. Now, in case of the vagus nerve, the Alderman's nerve is carrying a part of the external auditory canal as well as the tympanic membrane. So that sensation will be lost. The one nucleus that we haven't considered here is the nucleus tractus solitarius that carries the posterior most aspect of the tongue, taste sensation, and in case of the glossopharyngeal, also the posterior 1/3. of the tongue. So clinically this cannot be tested, but there will obviously be complete absence of taste sensation from the posterior 1/3 for glossopharyngeal and posterior most for vagus nerve. Okay, and of course both these glossopharyngeal and vagus do not have a GSE component, so we don't need that, and they do not have the SSA or special sensory afferent component. Okay, so I just want you to think over this again and probably use this table as a background on which you can construct the clinical anatomy of the other nerves as well. Just go to the component, understand what the component supplies to, and then you can automatically come to a conclusion of the clinical sign. Okay? Alright. Thank you so much for listening. This is a nice diagram that you could use if you ever have a LAQ on the vagus, right? Because it nicely shows the branches along with the relations to a certain extent. See you in the next one. Bye-bye.